All right, electrolytes. For you guys, so you've already seen electrolytes. You're going to see electrolytes again in block 3. So I'm going to spend most of the time on sodium, potassium, and calcium. We'll add in magnesium, phosphorus, chloride in block 3, so we can go in detail. Does that mean you're never going to need to know anything about them? Heck no. It just means that they're that important that we're covering it for 3 blocks. So it is important. You are going to have to know them. But for this test, my focus is sodium, potassium, and calcium. Those are the ones I want you to focus on. Those are our big ones. We'll go back over them again next block. You will need the normal values. All right? The NCLEX expects you to know the normal values. So you might as well get them in your head now rather than later, because it is something where they'll just put a sodium up there or a potassium up there and expect you to know whether it's normal or abnormal. So I'm going to just have you do the same thing. We're just going to put that bar up there. So I'm going to expect you to know the normals, and that's why we're just taking them 3 at a time. So sodium, potassium, calcium for this test.
So this exam, just those 3?
I will just put test questions on for those 3. And we will focus. Then you get all 6 of them next block. Because you get the other 3 added plus the 3 from this block. Because you studied it so well this block. So you will just have to review it next block. So, sodium, potassium, calcium. So you can get 3 normals. And you're going to have some. What I would suggest is get the normals down somewhere. For people who like listening to music, listen to a really good song that you really like, that you're not going to get sick of. And study to that song. So that you get the normals and just look at that, look at the whatever normals you're trying to memorize to that song. And then if you can't remember the actual normals, sing the song to yourself at the test and it will come back. It's one of those little tricks that you hear from memory gurus and stuff like that. So if you pick a favorite song or pick a good song, something with good lyrics and whatever that you can remember. Sometimes if you can't remember the values, you can remember a lyric and then the lyrics will tie to the value. Doesn't work for everybody, but it's one of those memory tricks, so I thought I'd pass it along. So let's talk about sodium. What does sodium do? Why do we have sodium? Well, one of the things is muscle contraction, but mostly it's our water balance. Mostly it is our water balance. Water will follow sodium around like a little puppy dog. So wherever the sodium is where the water is. So one of the big, sodium is involved in muscle contraction. And we need sodium for muscle contraction and nerve conduction. And that's the primary reason for sodium in the body. But sodium causes fluid shifting. If you have too much or too little sodium, fluid is in the wrong place. So one of the things that we see most common, the signs and symptoms of it, are due to fluid balance problems, not nerve problems. So that's why we can lose sodium from sweating, diuresing, laxatives. Anytime you lose fluid, guess what goes with it? Sodium. Sodium and water are like BFFs and they don't separate. So if you lose water, you're probably losing sodium too. If you lose sodium, you're probably losing water too. They go together. You can, though, if you end up with too much volume, you can dilute out the sodium. So there's another thing that I need to show you, another drawing. Let me draw another vessel for you. So we talked about the fluid shifting. Let's talk about electrolyte values for a minute. So this is a dehydrated vessel. And there's a lot of, what do we measure when we measure a lab? We measure sodium, calcium, glucose, all those things. So if we have very little amount of fluid in our vessels, what do we have? So we're going to take 1 cc of this fluid. What is in that 1 cc? A lot of stuff and not a lot of liquid. You're taking out very thick concentrated blood, right? Because you're dehydrated. So this is dehydrated. Let's just move over and draw a blood vessel that is super hydrated. So a lot of fluid and less of the little things and stuff because there's a lot of fluid. So we're going to take 1 cc of this fluid overload. So when you take 1 cc, so these are all the little things and stuff. So this is all glucose, sodium, potassium, calcium. When you take 1 cc of the dehydrated blood, what are you pulling out? A lot of those things: sodium, potassium, calcium, glucose, and not a lot of fluid. So 1 cc is still 1 cc of fluid, but in it is a lot of stuff. In this one, when you pull out 1 cc of fluid, is there a lot of stuff or a little stuff? A little bit. There's more fluid in there in that 1 cc. That 1 cc has more water than stuff. And in a dehydrated patient, that fluid, that 1 cc, has more stuff than water. So what you see on your labs, so let's look at the labs for these. What's your normal for sodium?
135 to 1.
So what do you think your sodium would be in a dehydrated patient? It's going to be high. It could be 146. But then when we put the right amount of volume into the system, and this is the right amount of volume and the right amount of stuff, we come up with 135 to 145. So my point is that you cannot trust a lab value until you are properly hydrated. Because what's going to happen here is you give fluid. You're adding more fluid to the system so that when 2 hours later you take 1 cc of blood, did we change your actual sodium amount in your body? You did not. You just diluted it out a little bit with some saline, some water, some whatever you put into the vessels. You put more fluid into the vessel, and then you took blood out of the vessel. So there's more fluid now when there wasn't before. Your sodium level never changed. Your calcium level never changed. We just took more fluid with the blood sample. And then if you're fluid overloaded and you take out that 1 cc, and there's a ton of fluid in that 1 cc and not as much stuff, it looks like, what's your sodium on here? You're like, oh my God, my sodium's really low. I need to fix it. But then, you give a diuretic or something, and guess what? Your sodium level comes back to normal. Or maybe they got, you did something or time went on. The problem is you don't want to replace your electrolytes until you are stable fluid, meaning you have decent blood pressure and decent urine output. Okay? How do we know that we're fluid resuscitated? How do we know that our fluid volume is as good as it's going to get? Yeah, they aren't orthostatic anymore. They have a decent blood pressure. Anything over 100 or 90 is decent, okay? We're going to take anything with these patients, but we're going to have no orthostatus. And what's your urine output going to be?
Equal with your input.
It's actually going to be at least 30 cc's an hour. It may not be equal. If your body needs that fluid, if you're this dehydrated patient, are you going to pee out the same amount you put in? Your body's going to keep that fluid because it needs it. So urine output doesn't always equal what you put in. So we can't tell. So we just look for adequate urine output. Okay, 30 cc's an hour is adequate urine output. If they're putting out at least that much, then we know the kidneys are probably, and of course then that depends on whether the kidneys actually work or not. When we talk about patients where the kidneys don't work, this all goes out the window. And sometimes these patients we can't get. They live in fluid overload. So we go ahead and replace their electrolytes because we're not going to be able to fix that. But as a general rule, if you're taking care of a patient at the very beginning, you'll see people come in and they're like, oh, we're not going to treat that electrolyte because it's concentrated, or that's not a true value. I don't know if you ever heard that in clinical. And you're like, wow, that electrolyte's really high. And they're like, oh, yeah, that's not a real value. And you're like, well, what happened? Did the lab do something wrong? No, they're just saying that the fluid isn't just right yet. So we're going to rehydrate the patient, and it's usually in dehydration. We're going to rehydrate the patient, and then we're going to recheck electrolytes. And if they're still low, then we'll replace them. Or they're still high, or we'll still do something about it. Because the thing is if you take your dehydrated patient, that sodium's 146, and you start doing all the interventions for high sodium, what's going to happen when you finally rehydrate that patient? That sodium could be low. So there's no black and white on those levels, okay? If I'm not going to say, what do you do for a sodium level of 146? Because it's going to depend on your patient. Are they having signs and symptoms of hypernatremia, or are they just dehydrated? Okay, so a little aside, we'll talk about it more when we talk about the interventions, but I did want to point out to you that dehydrated and fluid overloaded patients, their electrolytes may be off because they've got too much or too little actual fluid in their system. So electrolyte levels change. You'll see that people come in with normal hemoglobins, and then they rehydrate them, and their hemoglobin drops. And you're like, what happened? Did they bleed? No, they just got rehydrated. So when they first took that cc of blood, there was a lot of hemoglobin and not a lot of fluid. And then we rehydrate the patient, and it looks like their hemoglobin drops out. It didn't drop. It didn't change. We just put more fluid into that sample that we took out. So just think about that, and I will talk about it more when we talk about things as we go through renal failure and all that stuff. But lab values are only as good as your patient looks. So you can increase your fluid volume causing diluted sodium. Okay? So sometimes hyponatremia is a diluted system, and sometimes hypernatremia is a dry system. Okay, so a dehydrated patient may look like they have hypernatremia. In these two cases, if they have inappropriate sodium retention or increased fluid volume, we would need to check their fluid level first before we intervene. If they just sweated it all out or puked it all out or did something, then we can say you lost fluid and sodium. We can just replace the sodium. But if there's a condition going on that's affecting their fluid status, we may have to look at their fluid status first before changing the sodium level. Okay? Did we get that piece? That piece confuses a lot of people because they're like, well, which one is it? And, I don't know. Patients come in with all kinds of crazy stuff. So what you're going to look for is not just your sodium value, but signs and symptoms to go with it. Because signs and symptoms will trump a sodium value any day. If your patient is having signs or symptoms, then we're going to believe that sodium value and we're going to treat it, rather than waiting for it to see if it rehydrates or whatever. So with hypernatremia, what do you see as your top two problems for hypo or hypernatremia? Seizures. So you're like, well, which one is it? I don't know. You got to draw the lab and see. But with hypo and hypernatremia, you have mental status changes and a risk for seizures. Because hyponatremia, what is happening? Because remember, our big problem with sodium is fluid balance. So when you are hyponatremic, what does your blood vessels look like? When you pulled out that sample, is your blood vessel full of salt or not full of salt? Not full of salt. So it's full, we're going to call it dilute. Okay? What is happening if your blood is dilute? Where is the water going to go? Out to the cells. Because it's too much fluid dilute in here, it's going to go out to the cells. So hyponatremia causes cerebral swelling. Fluid's going out to the cell tissue. Now, do you have all over swelling? No, but it's enough in the head. Okay, the head is your problem with hyponatremia. Headache, confusion, swelling, and a risk of seizures. When those tissues are swollen, they don't conduct their stuff well, and you can have a seizure. What's happening in hypernatremia? You've got a lot of sodium. Where's the fluid going to go? Because fluid's going to follow sodium. You have a lot of it in the vessel. Where's the fluid going to go? To the vessel. Yay, to the vessel. And so the fluid all goes to the vessel and it leaves the brain. And you have cerebral dehydration. The swell. So in hypernatremia, the cells get dehydrated. Because hypernatremia means where are we measuring this salt? In the vessel. So hypernatremia means you have high salt in the vessel. Well, water's attracted to salt. It's going to go into the vessel and it will leave the cells, whether it should or not. So if you have hyponatremia, what was in the vessel? Not much salt. Where's the salt? In the cells. So the water goes to the cells. Because water is attracted to salt. It loves salt. Whether it's supposed to be in the cell or not, it's going to go there because there's more salt there. It's going to go to dilute it. That's what it does. It just follows it around. So wherever there is more salt is where you're going to find your water. So if it's not in the bloodstream, then there's more salt in the cell and water will be in the cells. If you're high natremia or you're high sodium in your bloodstream, water will go to your bloodstream and will leave the cells. So that may be appropriate, it may be inappropriate. But if it's inappropriate, your brain's going to start seeing the symptoms. It's going to be like either swelling or dehydrated. Either way, you're going to be confused, irritable, and you're going to have the risk for seizures. Okay? So with hypo or hypernatremia, I want you just to remember you're at a risk for seizures. Either one. Because it also works in your muscles, sodium's required for muscle contraction. If you don't have enough of it, you'll have weak muscles. And if you have too much of it, you don't have super strong muscles, just you got too much of it. So your muscles work just fine, and then you've got some extra. So if you've got extra hanging around, where is it? It's in your vessels, right? So not only is it pulling stuff from your brain, it's going to be dehydrating the rest of your body too. So you're going to feel dehydrated. Whether you are or not, I don't know. I have no idea what brought you in and gave you this high sodium. There are multiple reasons you can have high sodium. But if you have high sodium, that's what you'll look like. You'll look dry, whether you are or not, because your vessels are dry. You may have a blood pressure of 200. You may be weight volume overloaded in your vessels. But there's so much salt in your vessels that your cells are dry. So worry for hypernatremia. The takeaways are going to be, both of them, mental status changes and risk of seizures. Hyponatremia, you're going to have weak muscles because they can't contract. You don't have enough sodium to contract, so you're going to have weak muscles. So you're going to have weak reflexes. You're going to have whenever we have weak muscles, we worry about our lungs. Lungs, we have muscles that we need to breathe. So whenever we have weak muscles, these are not your only signs and symptoms. These are your main ones that I want you to remember. You have a risk for respiratory failure. So your muscles are weak. You have a risk for having weak breathing and ineffective breathing and respiratory failure. Nausea, vomiting, abdominal cramping. Why do you think you're having nausea, vomiting, and abdominal cramping? Your blood is not very salty. So where is the fluid going in your GI tract? Into the cells. It thinks it's full. You're not eating very well, and it causes a problem of imbalance. Whenever your body is in imbalance, its instinct is to throw up. Your nausea, vomiting is so non-specific. Anything can cause nausea, vomiting. So I want you to remember for hypo and hypernatremia, I really want the mental status changes as your risk and the weak muscles. Nausea, vomiting could really be on any of these lists because whenever your body is in imbalance, it will try to shut down the GI system and try to get rid of anything. So whenever your body is in trouble, you'll feel sick because it doesn't want you ingesting anymore until it figures out what the problem is, and it's like, dude, just no more food. Also, those cells get overloaded and overlogged, and so they think that they're full and they need to throw up. But nausea, vomiting goes with almost everything. So just toss it. Even if it's there, don't spend a lot of time trying to, this one has nausea, vomiting, this one doesn't. They probably all do. If you're out of whack, you're going to feel sick. Abdominal cramping is because you're full of fluid. Okay, your tissues are full of fluid because it's not in the bloodstream. The fluid's now going to the cells. So you're just full of fluid. But remember the cerebral for sodium. Sodium, cerebral. And then there is the extra additional problem of weak muscles and hyponatremia. So with sodium, our big problem is confusion because that's our big worry is cerebral edema or dehydration, depending on whichever one, if you're too high or too low. Risk for injury because mental status changes. Weak muscles goes with hyponatremia. So if you have hyponatremia, your risk for injury for both of these. If you have hypernatremia, you don't have as much weak muscles, but you're still at risk for cerebral dehydration. Risk for fluid volume deficit because the fluid shifting. All right, either there's hypo or hypernatremia, but as things fix or correct, your fluid's all out of whack. It's not in the right places. Risk for electrolyte imbalance. Anytime you have any of these electrolytes, guess what you get to use? Risk for electrolyte imbalance. Anytime you have a messed up electrolyte, that can be a diagnosis. It's golden for all of them. Risk for electrolyte imbalance or electrolyte imbalance. Yay, you got one. What are your interventions for electrolyte imbalance? Watch your electrolytes. Guess what? You've just got added to your care plan for any patient that has a weird electrolyte. Draw labs, check electrolytes. Every single patient, you're going to have to monitor their electrolytes. Just given. The worst case scenario for these is seizures and coma. Either one, because both of them cause brain problems. Either cerebral swelling or cerebral dehydration. So we are going to, this is a fluid shifting issue. We don't know if the fluid's in the right place. Our sodium's out of whack. Our fluid's going to be out of whack. So they get all these fluid issues as well. So eyes and nose, mental status, frequent checks and assist out of bed because they're at risk. They're at risk for cerebral dehydration and at risk for seizures. They may end up on seizure precautions if their sodium's bad enough. Either way. If it's way hyponatremic, they may end up on seizure precautions. If it's way hypernatremic, they end up on seizure precautions. Fall precautions. And for hyponatremia, you'll monitor for muscle weakness, making sure that they're breathing properly. Okay. Does that make sense? And of course, it goes without saying to monitor your electrolytes. I didn't even put it on there because it goes without saying. If you've got a low or high sodium and you're worried about them having seizures, you're going to want to see if it's getting better, right? So really the thing we're going to do is we're going to be constantly saying if they were confused and you gave them some sodium tablets or whatever, then you're going to make sure that that got better and that their sodium's returning to normal. So you can add monitor electrolytes to that because we are always going to monitor our electrolytes when they're off and out of whack. High sodium foods. You give them if their sodium's low. You don't give them if their sodium's high. We all know what high sodium foods are. That's it, right? That's pretty much all I want you to know. Now you can make it a lot harder if you want and memorize more. Go to town. But I really want you to remember the big ones with hyper and hyponatremia. Brain. Worry about your brain. Worry about your fluid balance. Okay? Got it? You good? Hey. All right, potassium. What does potassium do in your body? Why do we care about it? Heart. Potassium heart. I want your brain to think potassium heart. I just want it going potassium heart. It works in the muscles as well. It works in all these other things. But I want you to worry the impulse, transmission, and contraction of all muscle types, especially the heart. So this is going to have muscle problems and heart problems. This is what its main job is. So when it's out of whack, we're going to have problems with its main jobs, which is muscles and the heart conduction. We can lose it all kinds of ways. You can get too much. Mostly hyperkalemia comes with kidney disease. Most people don't eat too much potassium. Usually most people don't eat enough potassium. But when you start not peeing properly, the body regulates everything through the kidney. When your kidney's out of whack, everything's out of whack. So hyperkalemia usually comes with kidney disease, acidosis, so other problems, it's not because we just ate too much. It's usually there's something else going on in the body that's not regulating potassium properly. I'm not going to sit there and do a matching on things. Mostly I want you to know how to take care of these patients. I don't care that you know what the reason is. You have a lab draw. If you are seeing signs and symptoms and are concerned, you're going to draw your lab and you're going to do the monitoring that goes with it. So if you're concerned about hypo or hypernatremia, I want you to take care of your patient safely. All right, I'm not going to test you on what causes hypokalemia, what causes hyperkalemia. I just want you to know they have hypo or hyperkalemia and what to do about it. Yes?
When you're in the hospital, let's say you start believing you see signs and symptoms of hypo or hyperkalemia, are there standing orders that someone like who has kidney disease to draw labs, or do you have to call your doctor, give it SR, and then do it? I don't know, it's complicated. It depends.
It would really depend. And a patient that they know is going to have a risk for it, they go on the electrolyte protocol. Have you seen the electrolyte protocol in the hospital? They go, if they are at risk for fluid and electrolyte balance and the doctor's worried about it, they'll put them on an electrolyte protocol, which allows us to draw labs once a day and replace or take care of electrolytes as we need to, and then redraw electrolytes. So they generally, if they're concerned about their electrolytes or you're concerned about them, you can ask if they can go on the electrolyte protocol. And then there's like there's a potassium electrolyte protocol. Sodium's not really a protocol because it's so dangerous with the fluid shifting that actually there are usually specialized doctors watching and helping us get that sodium back to a normal level. So there's a potassium and a magnesium and a phosphate electrolyte protocol. But usually sodium is so risky because we are messing with fluid balance that they don't let us just fix salt. Salt has a lot of implications. Like everybody's like, oh, it's just salt. It's really like if you ever watch a patient that comes in with hyponatremia, they actually get a renal consult and the renal doctor follows it. It has to get changed slowly. You can't just give them a bunch of McDonald's or salt tablets and change it, because if you flip it too fast, they fluid shift and seize. So sodium is a very delicate balance that we bring it down and bring it up very slowly and very carefully. So sodium is actually like, you think, oh, potassium involves the heart, but we have a protocol for that. Sodium, we don't have a protocol for. That has to be watched very carefully every 6 hours, and it has to be brought up very slow. They lose their minds if the sodium level goes up too fast, or if the sodium level goes down too fast, because you're causing fluid shifting all throughout the body, especially the brain. So for potassium, I want you to recognize the signs and symptoms of potassium. So if for some reason you got your patient on a heart monitor and started seeing stuff, and you saw other signs and symptoms, and they have a reason that they would have lost electrolytes, I want you to be concerned. But what you're going to see in potassium is a specific heart changes. Hypokalemia, everything is low, everything is slow and depressed. So they have depressed ST segments, and they have this like little blip on the back end, but depressed ST segments. Hyperkalemia, everything's hyped. That heart is hyped. So it is super, super excitable. Its rhythms start getting higher and higher. That ST elevation starts climbing. That T wave starts climbing. Everything starts climbing. And actually what's happening there is the potassium's involved in conduction. So if the potassium's not working properly, the conduction doesn't start working properly, and the longer you're in high potassiums, your QRS just starts widening. It can't conduct properly. It takes a long time to conduct, the higher your potassium is. So you start losing your QRS. You can code from either one of them, but hyperkalemia can definitely send you into a code very, very fast. So hypokalemia's got a little bit more room before you would code, but hyperkalemia doesn't have a lot of room.
The NG tube, why does that cause hypokalemia?
What are you doing with an NG tube? You're suctioning out what?
Gas tube.
gastric contents. And there's a lot of electrolytes in your gastric contents. Just like when you puke or have a lot of diarrhea, you lose electrolytes that way. NG tube is really just a suction for your electrolytes coming out. So you lose a lot of electrolytes from NG just like you would from diuresis or diarrhea, either one. So if you are hypokalemic, your heart is depressed. If you're hyperkalemic, it's super hyper and can go like tachycardic at a moment's notice. Not super tachycardic, like ventricular tachycardia, like the bad tachycardia. So there are EKG changes with both of them. They do look a little bit different, but hyperkalemia has much more of a risk of cardiac arrest. Tall, peaked, and then as it gets higher and higher, that QRS it stops conducting, and you go into a VTAC. But because K is for your muscles, it's just like sodium, it's required for your muscle contraction. So if you don't have enough of it, your muscles don't contract very well and they get weak. If you have too much of it, you can get twitching and cramps. Okay. So weakness, fatigue, shallow respirations is a problem there. Twitching, cramps, and possibly even if it gets too bad. So you're probably going to have heart problems before you're going to have respiratory problems with hyperkalemia. But they can cause respiratory problems because these muscles get so overexcited and they get stuck. You actually end up getting like some paralysis, like where you'll like get like turgor and stuff if your K gets too high. Most patients code before they get to that point. So, hey, you don't get there. But muscle paralysis is pretty rare without the massive EKG changes. But you can get twitching, cramps. Basically, these muscles stay hyperexcited, hypercontracted, and they can't relax very well. They stay hypercontracted. Whereas in hypokalemia, they just have trouble contracting. So same almost as sodium. Sodium doesn't get when your sodium gets really, really high, you end up having a seizure before you get to any muscle twitching or paralysis or anything like that. But potassium, you do see muscle dysfunction sooner than you would on the sodium. So with potassium, you're worried about your heart and your muscles. Sodium, you're worried about your brain and your muscles. But sodium is heart and muscles. Okay. Why would you have decreased intestinal motility and some mental status changes with hypokalemia?
Because of the muscle?
Yeah, the muscles are slow. The smooth muscles as well are being regulated by potassium. So when they slow down as well. So intestinal, mental status. What's it?
Sorry. Are the muscle cramps you're talking about the kind you get like?
They feel like Charlie horse kind of cramps. Yeah, high potassium is Charlie horse cramps. Now you can also have muscle cramps with low potassium, but it's kind of hard to tell. So because Charlie horse can be from those strong muscle contractions, cramps can be from hypokalemia too. But this is basically where the muscle gets frozen, kind of not contracted, but like stuck. It just can't.
So bad.
Yeah, it can't regulate very well. And the thing is I really want you to not function. I'm not going to ask you a question, which one causes muscle cramps, because they both would. Okay, it's not specific to this, but what is specific is the combination of heart and muscle. That is very specific to potassium. Every single thing with potassium, I want you to think heart, because the biggest problem is potential for dysrhythmias. On both of them, both sides have problems with dysrhythmias. So they can't conduct, we're worried about the heart. If they have some muscle weakness, of course everybody's electrolyte imbalance, everybody's risk for injury if they're all off. But I want you to remember cardiac arrest and respiratory distress. So for sodium, I want brain and respiratory distress for hypo. For potassium, I want heart and respiratory distress for hypo. Okay. Put the patient on an EKG monitor. That will be your first intervention for any potassium. If you're starting to have cramping and you think you might be low on potassium, I want you to put them on a cardiac monitor. Because by the time you draw your labs and wait for labs to come back in an hour, they could be having some serious heart problems. So if your patient is hypo or hyperkalemic, they should be on a heart monitor. All right? Because if it goes too far the other way, we could have some big problems. So the patient needs to be on a heart monitor. You can draw labs. Just put them on a heart monitor first, because then while you're waiting the hour for labs to come back, heart monitor. Let the doc know you're concerned. Why would you be concerned about hypokalemia if you don't have a lab yet? What are you seeing that would make you concerned about hypo or hyperkalemia? What would your patient be telling you? They may be complaining of weakness. Maybe they've got some reason that they're, they would have lost potassium. Maybe they're dehydrated. Maybe they have an NG tube. Maybe they've got some reason. And they're complaining of weakness. This patient will complain of weakness before a sodium patient. Okay? They're like, wow, I'm feeling a little bit weak. Or I'm feeling like a little bit twitchy. Anytime your patient complains of muscle fatigue or muscle twitching, go get some labs. But what is it going to hurt to go ahead and put them on a monitor too? If the doc doesn't want it, you can take it off. It's a non-invasive intervention. Just requires some stickers. Put them on a monitor. Because if you wait to get an order and draw labs and wait for the labs to come back, that could be an hour or two. And if that potassium is really bad because it's causing muscle weakness, what else is it causing? Conduction problems, because it's going to affect the heart first and then the muscles. So if it's affecting the muscles, you're going to want to watch the heart. What else might they be telling you that they have? Palpitations. If a patient's complaining about muscle weakness and palpitations, please put on a heart monitor and then check your electrolytes. Because it could be anything. Could be sodium, could be potassium, could be calcium. But at least you're covering the heart, right? At least you're making sure that one's okay. And then what else are you going to be monitoring for the patient that has weak muscles and palpitations? Your respirations, because you're worried, hey, if their muscles are already weak, are they taking adequate breaths? This is a patient that you've got to look at. Okay. So, and then we're going to, of course, treat it. Once we get the lab value back, we're going to treat it. If they are low, you can give them potassium foods, which you're going to have to know the foods that go with all these electrolytes. I have a slide on each of the foods, so just kind of know if it says high sodium foods or low sodium foods, high potassium foods, low potassium foods, you know what those foods are. High potassium diet, potassium supplements. Just about the meds, if you give them oral potassium, give them with water or juice. These are stomach irritants. Potassium as a med is really irritating. It irritates no matter how you give it. It irritates the stomach if you give it orally. It really irritates the veins if you give it IV. It is just an irritant. It's really irritating. So give it with water or juice to reduce the stomach irritation. You can give it with food. That's perfectly fine too. It doesn't need to go on an empty stomach. IV supplements, though. If you're giving IV supplements, there are strict rules with potassium. If you push IV potassium, what can you do? You can kill somebody. That was actually my method of choice for my husband. I was like, dude, I'm going to bring home some potassium. But because they used to give it in little vials, and you could pull it up, and then we'd dilute it and give it. They don't even let us have vials of potassium anymore. It's so dangerous. You know how they stop a heart for heart surgery? They bathe it in potassium. It will stop a heart. So when you're giving potassium, you have some power in your hands. But you don't give it, it's never an IV push, because you can kill people pushing potassium.
Is this one of the drugs you check to, like your nurse?
It's not a 2RN double check, as far as I know, because we can't give it push. I mean, they don't even allow it anymore. It's actually what they give for lethal injection. Really? It is. They give potassium. So, just be like, hold the potassium, be like, wah. But you don't get it in a vial anymore to push it because it's not even available that way.
So you have to have a lot of fluid.
You would have to give a lot of fluid to give enough potassium to kill a person. Yeah, they took that away from us. I wonder why. Maybe there were enough of people like me who are like, I'm going to take some potassium. Anyway, did you ever watch Pulp Fiction where they do the little ejection into the heart?
Yes, that's like the second worst scene of that.
Yeah, that's actually epinephrine straight into the heart. But if you did that straight into the heart, it would stop instantaneously. That's how strong potassium is to the heart. The heart and potassium are like this. So we'd never give it push. I don't even think we can anymore, even if you wanted to. It comes in pre-mixed bags, and it comes in 10 and 20 milliequivalents. If you're going to put it in a peripheral line, You can't give more than 10 milliequivalents an hour. Okay. This is a strong, irritating electrolyte. It's very irritating. If it infiltrates, it will kill the tissue around it. So we don't want it irritating. It also is irritating to the vein. So as it's infusing, it hurts. A lot of patients complain about potassium. Sometimes they even give lidocaine with the potassium to infuse it IV because it's very irritating. And when it's going in, it doesn't just hurt, it does damage the vessel a little bit. So if you're giving a lot of potassium peripherally, your vessel may infiltrate. So keep an eye on potassium. I want you to be awed by the power of potassium. So it's very irritating the vein and very necrotic if it infiltrates. So this is a patient where, and I asked the class on a test in another block how fast you would give potassium. And they'd forgotten. Someone put it was okay to give over 30 minutes. And I'm like, wrong! You don't give peripheral IV potassium over 30 minutes. You don't even give central IV potassium over 30 minutes. Potassium goes over an hour. And it's usually 10 milliequivalents an hour at most, unless you have a central line, and then you can do 20 milliequivalents an hour. So there is no giving 40 milliequivalents of potassium IV in an hour. It's 10 an hour peripherally, 20 an hour centrally. Okay? Be in awe of potassium. It's there are rules.
When are they going to redraw labs to see how the potassium is affecting?
So that's a good question. When would you redraw labs? So IV, you can redraw sooner than if you give it orally. Orally, it's going to take a while. They usually withdraw in 6 hours after you give an oral dose because it's going to take a while to digest and get into the bloodstream and ramp up to the level that you want. IV, you can check it in about an hour or 2 hours after giving it. But usually it's 6 hours oral and usually an hour or 2 after peripheral or central. But basically, remember IV potassium no more than 10 an hour. Okay? Because even centrally, we just get a 10 an hour unless it's really bad. But 10 an hour, be careful with it. It's necrotic. Hyperkalemia. They have too much potassium. What can you do? Well, you don't let them have any more. So you know your potassium foods, and you're like, no, you can't have those. There are medications that you can give specifically for potassium, and that big one is K-Exolate. K-Exolate is a drug that you use in your gut, and it will bind potassium, suck it out of the bloodstream, and then you poop it out. What do you think if you're pooping something out and you're removing potassium from the gut? K-Exolate will give you some diarrhea. Anytime we're binding and getting rid of stuff, it gives you a little extra. But K-Exolate will bind and remove potassium from the gut. Do you think it takes a long time to work? It works pretty good, but it takes a while to get your potassium level down from K-Exolate. Couple hours, all right? Couple hours. So, you give a dose of K-Exolate and it comes down a little bit, and you give another dose and it comes down a little bit. Not very efficient for fast removal of potassium. So it's the gold standard, it's the best. But let's say we're having EKG changes and our patient's close to that code status. We don't have a couple hours to get that potassium down. There are a couple of things that will get it down faster, but not as efficiently and not as good as K-Exolate. K-Exolate is the one you want to remember for potassium. But if you see these other ones, they will basically either hide it or remove it from the body. So diuretics gets rid of potassium pretty fast, because what's it going to do? You're going to pee out electrolytes. You're going to lose potassium. So diuretics are really great for losing potassium quickly, but if you can handle the fluid loss that goes with diuretics. Some patients can't handle that fluid loss, so we can't give them the diuretic. But diuretics are great IV for removing potassium, but you got to be able to handle removing fluid as well. Dextrose with regular insulin. You're like, what? It doesn't even work, right? Why would you give dextrose and insulin for potassium? Well, there's a fun little fact that will come up again when we talk about DKA next block. But potassium kind of shuttles with glucose into the cell. So when insulin opens up the cell for glucose. When insulin says, here, have some glucose, and the glucose goes into the cell, potassium goes along with it. It's like a little stowaway or something. So when glucose is going into the cell, potassium goes with it. So what we do is we will give insulin. Blam, we give them like 10 units of insulin. So what's going to happen to the potassium? It's going to shuttle away from the bloodstream and go into the cell. What happens when you give insulin? It lowers your blood sugar. These patients aren't diabetic. They're not getting insulin because they were diabetic. They're getting insulin because we're trying to push the potassium out of the bloodstream. So we have to give dextrose with it so that they don't become hypoglycemic. It's a temporary, it's basically just shooing the potassium away from the heart. It's shooing the potassium into other cells in the body so that the heart can't code, basically. It's a quick thing that they'll do. You'll see it in the ER. You'll see it in someone that's super, super hyperkalemic, that they're waiting for dialysis or something to get rid of it, that they'll do as a quick fix method. It doesn't work forever, as the potassium finds its way back into the blood vessel, and the potassium level goes right back up. It's very temporary, but you may see it. And calcium gluconate does not fix your potassium, but it immunes the heart to the effects of potassium. So calcium gluconate is given for hyperkalemia. And you're probably like, I don't understand why. You don't need to understand why. It just immunes the heart to the effects of the potassium. It overrides the heart from listening to the potassium, so it won't code on you. So calcium gluconate we give that not because their calcium level's low, but because their potassium level's high, and it's so high that we basically need to immune the heart to the effects of it until we can get rid of it, until the Electrolyte can work, or until dialysis can come in. Sometimes the potassium's so high that we need to get rid of it right away, and the best way to get rid of it is we've actually dialyzed people to get rid of the potassium. So these are the diuretics, the insulin, and the calcium gluconate are kind of temporary quick fixes, but they won't fix the actual hyperkalemia. The only thing that's going to fix hyperkalemia is Electrolyte or dialysis. And I guess diuretics would fix it if you could get rid of the fluid with it, because it'll get rid of the... But dextrose and calcium don't really actually remove potassium from your body. They're just temporary quick fixes. So you may see calcium gluconate as a treatment for hyperkalemia. Not really a treatment, just a buy us some time until the treatment can work. And the treatments are Electrolyte, diuretics, and I should probably put emergency dialysis. Those are what's going to actually remove potassium from your body. And there's your potassium foods. So if they want their banana with breakfast and they have a high potassium, no. Citrus juices have potassium in them. So if they want their orange juice and they have a high potassium, you might want to ask them about, apple juice or grape juice, but probably not grapefruit juice or citrus juices. And grapefruits have a huge amount of potassium in them. Huge amount. Calcium. Now we're going to go to lunch after calcium. So calcium I like to think of as needed for relaxation. So we needed sodium and we needed potassium to create contractions, right? Because if we didn't have enough of them, they would cause weak muscles. This one, calcium, is the opposite of sodium and potassium. You need it to relax. It basically, that's very simple. But you need calcium in order for things to relax. Because if you don't have enough calcium, what do you think is going to happen? You're going to get tense and seize up. You can't relax. So think about it as you can't relax if you don't have enough calcium. If you have a lot of calcium, you can relax. Makes it kind of simple. It's not really how everything works in the body, but that's how you can make sense of the signs and symptoms. It's also good, bones and teeth or whatever, but really what our signs and symptoms are going to see with calcium is muscle. So whereas sodium was brain and muscle, potassium, heart and muscle, calcium's all muscle, really. Almost all muscle. So what are we going to see with hypocalcemia? Most of the time they don't eat enough of it. You have a vitamin D deficiency. We talk about all these other things as we go through block 3. Hypercalcemia, you have too much vitamin D. Why would prolonged immobility cause you to be hypercalcemic? So you're not walking around, you're not weight bearing on your bones. What happens to your bones? They start to break down. So as your bones break down, they release calcium into the bloodstream. So prolonged immobility, that's your bones disintegrating. That's what it looks like. It looks like hypercalcemia. Blood or bone problems. That bone reabsorption is what it's called when your bones are breaking down. So your bones can break down, and it's called bone reabsorption. Some diuretics, again, I don't spend too much time on what causes it. I just care whether they have it or not. Hypocalcemia. Your muscles can't relax, basically. You end up with tremors and twitches. So I like that cat. Hypocalcemia, you end up with tetany. Okay? If you have too low of calcium, you end up with tetany. Do you know the Trousseau's and Chauvet sign? You remember those from last block? Which one's which? The Chauvet is the face. Twitch them and they'll twitch their face. Trousseau's is the hand going like this. We see Trousseau's more often because when would this happen? When you're taking a blood pressure. So if you're taking a blood pressure and their hand does this, you can scrape their cheek and you're probably going to get this. And what is that going to be? Hypocalcemia. So if you see Trousseau's sign, you can confirm it with Chauvet sign. Of course, they'd have to have normal facial. Someone with a stroke may not have Chauvet sign. But this is something where you stroke your facial nerve and you get a twitch. Or maybe they're just twitching, even without any stimulus. So you will see those with those. Why would you have seizures? We didn't talk about the brain. This one's not a brain one. Why are they having seizures? It's actually not from the brain. It's from the muscle. It's a muscle seizure. So tics, like seizures. But if you have a full body seizure, it's from full body muscle twitching. It's muscle twitching. It's not a wrong signal from the brain. It's just muscle twitching. Stridor and laryngospasm. What is that from? It's a muscle spasm of the respiratory tract. So these are muscle spasms, all right? Twitching, spasms, to the point where you can even have seizures, okay? Hyperactive deep tendon, do we know what that means? You bang their muscle and it goes up. That's hyperactive. Hypoactive is when you bang something or their knee and it barely moves at all. Hyperactive is a sign that your muscles are whoop. They're not really, they're just like going, man. There's also numbness and tingling around the mouth. Why? I don't know. It's just a cardinal sign. So if you have a patient that is complaining of numbness and tingling around their mouth, and there's no other reason for them to have that, and you take their blood pressure and they do some twitching, touch their face and they're doing some twitching, what are you going to look for? Calcium, okay? Twitching, numbness, tingling, spasms, and you're at risk for seizures and laryngospasms. So, of course, I'd probably want you to take a listen. Listen to their airways. If you start hearing wheezing or tightness or stridor, that's pretty bad off. You've got some pretty bad hypocalcemia. This also does affect your heart as well. It just prolongs your QT interval. That's just an extra sign. I'm never going to say, oh, you have a prolonged QT interval. It's an extra sign. I'm probably going to give it to you on top of everything else. When I give you a patient, he's going to have signs and symptoms of something, and you're going to have to recognize it. And that's really what I want you to be able to do, is recognize these conditions in a patient. So there probably wouldn't be one sign. It's probably going to be a combination of 2 or 3 that are going to be like, oh, yeah, that's what this is. Hypercalcemia is severe lethargy. So it's basically the opposite of sodium and potassium. So whereas sodium and potassium, hypo, gave you the lethargy and the respiratory failure, hypercalcemia gives you lethargy and respiratory failure. Why couldn't we just be made that everything makes sense? But there is so much pathophysiology on the surface of how these muscles contract using all these electrolytes and how your heart contracts using all these electrolytes that if you wanted to take pathophysiology and go into it, you could. That would explain more, but I'm trying to make it basic and what I'm really going to have you look for. And so if you are lethargic and having shallow respirations, it could be sodium, potassium, or hypercalcium. It could be low sodium, low potassium, or hypercalcemia. So I'm probably not going to give you respiratory failure as like your only clue, because it could be 3. So I'm probably going to give you some other ones to go with it so that you can help figure out which one it is. Because, yeah, there are a lot of symptoms that are all the same for multiple ones. But respiratory failure, weakness, coma for hypercalcemia. They can also have slowed cardiac conduction. The other thing, kidney stones and nausea, vomiting, constipation, pain. I forget if I had the picture on this one. No, I don't. I got rid of it. These little pictures came from, these were the signs. Twitch is a mnemonic for hypocalcemia. It stands for tetany. I don't remember what W stood for. I'm not a big mnemonic person, but if you are, you can look up mnemonics to go with it. Twitch is one for hypocalcemia. And I always remember the cat, like, ah. This one is stones, groans, aches and bones, or something like that. Stones, groans, aches and moans, or something like that. I think it's stones, groans, aches, and moans for hypercalcemia. And so I took the pictures from that one. So stones are from, you have too much calcium in your body. Calcium turns into stones in the kidney. So you get a high risk of kidney stones. Groans are from intestinal distress. Everything's slowed. Okay, smooth and regular muscles are slowed. So a lot of nausea, vomiting, constipation, pain. And the mental lethargy. Just everything's kind of slowed on you. All right? Everything's lethargic, even your brain. So, I mean, I don't know. When you get me in the morning, I could be hypercalcemic. I don't know. I'm groaning and moaning, and my brain doesn't work. But anyway, you can look up however you want to remember them. I don't want you focusing on a giant long list. I want, like, the main things, because those are the things that are really important. With calcium, most of your issues are going to be muscle and a little tiny bit of cardiac. With potassium, most of your issues are going to be cardiac with some muscle. And with sodium, your issues are going to be brain, fluid shifting, and a little bit of muscle. Okay? And what do we do for calcium? Well, what were our big problems? What were our big worries with hypocalcemia? Seizures and tetany. So I want you doing seizure precautions, doing fall risk for anybody that is a seizure precaution. And then the Trousseau sign, monitor your heart rate, your blood pressure, lung sounds. What are we listening for in hypocalcemia for lung sounds? Any stridor, any laryngospasm, any extra new wheezing. And then with hypercalcemia, you're going to be listening for the respirations. So you can kind of go through, and those are the things I want you to look for on them. But since this is mostly muscle, I'm going to want you to probably just keep an eye on their deep tendon reflexes and their muscle stuff too. See if it's getting better. What do we do to treat them? We give them calcium if they're low. So they can have tons of food high in calcium. They could take oral calcium. Calcium, though, when we just take it by itself, is not absorbed. It needs vitamin D to be absorbed out of the gut system. So we could take 5,000 milligrams a day of calcium. If we don't have any vitamin D in our system, it just gets pooped right out, doesn't get absorbed. It has to have vitamin D with it. So should be given with vitamin D, better for after meals while it's all being absorbed. It doesn't go well on an empty stomach, given after meals usually. IV calcium, because we give it IV, this is not as, don't be in as an awe of IV calcium, but you can give IV calcium, and because it does have some cardiac effects, they're smaller than potassium, but because it doesn't have cardiac effects and we're giving it IV, I would want them on a monitor as well. if you're going to give calcium. Because what's going to happen if you up the calcium too fast and it starts going high? What's going to happen to your heart rate? It's going to slow down. So it's one of those things that if you're on a heart rate monitor and you see your heart rate slowing down while you're giving potassium, you might want to stop the potassium infusion and take a look at what's going on. It is also irritating to the veins as well and necrotic if it infiltrates. Okay. So anytime we give electrolytes, just be very careful around their veins. Check them after. When you give IV stuff, we'll talk about next block when you're giving IV meds, to flush before and after. Flush after, because a lot of times your vein just went bad during that infusion and you want to keep an eye on that vein. If they're hypercalcemic, the big treatment is fluids. And why would the big treatment be fluids if you have too much calcium? To dilute it. Because we're worried about all that calcium causing stones and things. It needs to be flushed out. We want to flush it out. So diuretics and fluids are our main, like they'll give diuretics because you'll lose some of it. You'll lose all your electrolytes, but you'll lose calcium along with it. So you want to be careful with the diuretic. But fluids will flush it. So usually the treatment for diuretics is just a lot of fluid. Just like the treatment is for kidney stones. If you have a kidney stone or an infection or anything we need to flush through, you're going to get super fluids. So almost 3 to 4 liters of fluid. So we would send someone home with hypercalcemia. You got to drink a lot of fluid. You got to flush this stuff through. You're going to block up your kidney. So a lot of fluids. Oh, I hate when this thing does this. You can do calcium binders as well. There are calcium binders out there, which will take a while, but you can put it in the gut and it'll bind calcium and poop it out. And then you can do fiber because everything slows down and prevent constipation. And everybody should know calcium foods. So, here it comes! So, we're going to do lunchtime. So, 45 minutes? Is that what we normally do? 45 minutes? I'll be back in here by, we'll say 11:50. Is that fair? Is that the right time?